Dear EAO friends from all over the world, my name is Alfonso Gil and I am thrilled to be back with you for the EAO Digital Days. The reason why you should watch this video is because together we will think outside the box and we will resolve in a very unconventional manner a complex and anesthetic implant recession case. The aim of this video and of this presentation is to show to you the coverage of this peri-implant mucosal recession with the Vista technique, Vista, walk you through the clinical steps of the procedure, and finally show you the outcomes. Let's introduce our patient. She's a 58-year-old female. She works as an air hostess. She has recession on 1-1, healthy patient, non-smoker. Implant was placed 20 years ago with GBR. It's a brown arc implant, which was restored with a single unit cemented restoration. Here you can see the recession. It's around 2 to 3 millimeters deep. You can see the zirconia abutment exposed and the deficiency of volume. Now, from an occlusal standpoint, we can also see the crown is more buccal than the rest of the teeth. This is due to craniofacial remodeling. You can also see the discrepancy in the incisal edge. The crown was probably not cemented like this, but this is what has happened. Now, it's important to also show that the implant is healthy. We don't see any marginal bone loss here. From a clinical perspective, we also see that the implant is healthy. There is no pocket, there is no suppuration, there is no BOP, and in general, there's no signs of disease. Now, these are the important factors that you should take into consideration. Case selection is the most important thing for implant recession coverage. Should we keep the implant or should we extract? We said it was healthy, so we can keep it. Should we treat it or not, depending on the health? In this case, it is healthy. And then finally, which technique should we use? Should we use only surgery or should we use a combination of prosthodontics and mucogingival surgery? It is the latter that has been shown to be more predictable for implant recession coverage. Restoration is then removed and we can see already the gain in tissue in height just by removing the crown. Now, the choice of technique, we said we were going to use Vista, vestibular incision, periostal tunnel access, and this offers 3 clinical advantages. Remote surgical access, we do not operate in the most important part of the surgery, which is the mucosal margin. We can increase the thickening of the mucosa thanks to that vertical incision where we introduce the graft. And finally, the huge coronal advancement of the tissue. Clinical factors that make this case worth treating. Preserved attachment of the adjacent teeth. They have recession, but the patient did not want us to treat it. We have a medium thickness of the periodontium. We have a healthy implant, not too buccally placed. And even though the band of attached keratinized mucosa is thin, it is still present. Now, the surgery started with 2 vertical incisions. These are done in the vestibule, all the way deep down. And through them, the tunnel starts to be created. Here you can see the 2 incisions, mesial and distal to that implant. And we start with a full thickness tunnel, superiostal tunnel. The idea is to release distal of 2-1 and distal of 1-2. So we have enough space, first of all, to coronally advance that tunnel, and second of all, to place and stabilize our graft. Here you can see the passivity of that tunnel. It's very flexible. We have a very good release, and that will allow us to place the graft buccal and coronal to that implant. It is time for the harvesting. So here we use a Zucchelli technique in which we de-epithelialize, first of all, in the mouth with a burr, that graft, we remove the epithelium. How do we know when we removed enough? Because it bleeds. The blood vessels are in the connective tissue, so they will bleed. That's how you know. After that, we do the 4 incisions, and we start to liberate that graft around 1.5 millimeters thickness, not more than that. We do not want to go to the bone. Why that thickness? Because we know that that superficial connective tissue graft has more fibers, less tissue, and less blood vessels. Here's where we finally cut that graft, where we now remove it. Here you can see a beautiful picture of it, very clean, very fibrous, and we will now use it through that vertical incision. Here you see the first suture, polypropylene suture, 6-0, going through, first of all, through the tunnel and into that vertical incision. Then we take 2 bites on the graft, as you can see there on the left side, and then back through that entry point. This allows a point of pulling for that graft, as you see right here. And we just leave it there. This is the distal line angle of the implant. Now we go on the mesial line angle of the implant, again, through that tunnel, outside in, inside out through the vertical incision, twice through the graft, and then back through that vertical incision through the entry point, inside out. Now we have two points of pulling, and we will now pull both sides coronally, and the graft will come. The sashimi will come. What you can see right here. Now we make use of a Castro Viejo or of a elevator to stabilize the graft exactly at the point where we want, which is buccal and occlusal of that implant. Here you see the two stabilizing sutures with very clean and in the correct position with no tension whatsoever. Then we cement the provisional, which is a resin bonded bridge on 2-1 and on 1-2. And we use these Sling sutures that take a bite on the tunnel to coronally advance the whole tunnel. You see through these sutures how the tissue is coming down. As you can see in the picture, we're now positive. In relation to the adjacent central, we're in plus. Please see the stable positioning of that tissue. If we move the lip, it does not move. And then finally, the vertical incisions are approximated with that polypropylene suture. We wait 2 weeks in order to remove the sutures. You see uneventful healing, almost with no inflammation. And then after 4 weeks, this is the healing. No more recession, it's covered. In the meantime, it's being with a resin bonded bridge, and after 3 months, we connect the implant provisional. Why? Because we want to develop the emergence profile. Here you see it at 6 months with a beautiful emergence profile with a lot of thickness that we can use to push and emulate a natural appearance. And here we have the zirconia, veneered zirconia crown that is then introduced into that beautiful and natural emergence profile. Let's see where we started. We started with recession, with exposure of the zirconia abutment, with those folds in the tissue like scars, with insufficient keratinized mucosa, and with the discrepancy in the incisal edge. This is the final situation where you see we were able to cover the recession, we were able to increase the mucosal thickness, we were able to restore the incisal edge and the color to have the same symmetry as tooth to one. And finally, we provided the patient with an aesthetic, functional, and healthy solution. We have 3 conclusions for this presentation. The first one, case selection. If you want to treat recession around implants, you have to select the right patient. Healthy implants, adjacent healthy teeth, and a position of the implant that is not too buccal. Second conclusion, restorative and a surgical approach is more predictable. Third conclusion, Vista, thinking outside the box, will provide a series of clinical advantages that will make us more predictable, more aesthetic, and less invasive for our patients. With that, my EAO friends, I say goodbye, and I hope to see you soon.